Hi, this is Marisa, and today I am reporting to you about RT, who is a 54-year-old man who is presenting to the clinic with complaints of depression, mild shortness of breath, and trouble breathing during exercise. RT reports he suffered a terrible depression since his heart attack in 2015, and he's been depressed consistently for the past 6 months, described as constant feelings of guilt, fatigue, worthlessness. He is less interested in spending time with his friends, his hobbies, and he has difficulty concentrating at work. His depression is particularly difficult with cold weather and holidays, and was previously treated with citalopram about 2 years ago, which worked well, but he discontinued due to erectile dysfunction and diarrhea. He is actively seeking treatment for depression, and he desires to take control of his life again. He states he is willing to try to quit smoking, and if he could breathe a little bit better, he is willing to start an exercise program. He gained 15 pounds over the last 6 months, and he has been eating more over the last 3 months. His current weight is 190 pounds, and his current height is 71 inches. His past medical history includes COPD with an exacerbation in March of 2017. However, he was negative for alpha-1 antitrypsin deficiency. He had a STEMI 3 years ago, which is attributed to his lifestyle, depression, obesity, dyslipidemia. He currently smokes 1 pack per day, and he has a family history with CVD and depression. His current medications include metoprolol 50 milligram PO daily, fluticasone 100 microgram 1 puff BID, albuterol meter dose inhaler 2 puff every 4 hours, PRN shortness of breath, atorvastatin 80 milligram PO daily, aspirin 325 milligram PO daily, and he has an allergy to adhesives. His prioritized problem list includes uncontrolled depression, uncontrolled COPD, uncontrolled obesity, new QTc interval prolongation, renal insufficiency, and abnormal hepatic function. For assessment of his COPD, the patient has no signs of bronchitis. He is saturating well on room air at 95%. His respirations are at 18, however, mild wheezing is evident. His FEV1% predicted post-bronchodilator is 52%, and severity of airflow and limitation classification in COPD is moderate, which is between 50% and 80%. The patient presented at 52%, and this is based on GOLD guidelines. His combined COPD assessment or impact on the patient using his CAT score of 21, spirometry, and symptoms or risk of exacerbation puts a patient in Group B for low risk and more symptoms. And the recommendation is to consider regular treatment for his symptoms based on GOLD guidelines. For his goals of therapy, the ACP guideline 2011 update recommends to prevent and treat exacerbations, reduce long-term lung function decline, reduce hospitalizations and morbidity and mortality, relieve disabling dyspnea, improve exercise tolerance and health-related quality of life. And the GOLD lines also include to assess and treat comorbidities routinely. And the rationale behind this is that comorbidities independently influence mortality and hospitalization, and they need specific treatment. For the plan for COPD, I recommended a smoking cessation plan with nicotine replacement therapy. However, we will need to discontinue planned therapy with a nicotine patch because the patch is inappropriate due to the patient's adhesive allergy. I recommended the nicotine mini lozenge, 2 or 4 milligram over the counter, based on when the patient has the first cigarette of the day. And this is FDA approved for smoking cessation. The patient can start 1 lozenge every 1 to 2 hours for 6 weeks, then 1 lozenge every 2 to 4 hours for 2 weeks, then 1 lozenge every 4 to 8 hours for 2 weeks, with a maximum of 20 lozenges per day. And the rationale behind the nicotine replacement therapy is that it reliably increases long-term smoking abstinence rates when combined with pharmacotherapy based on GOLD guidelines. For safety, we will monitor and advise the patient to report any untoward or unexpected events that he feels that are associated with the lozenge. And for efficacy, we will look to see if the patient has the ability to stay on track with the standard trial for nicotine mini lozenge and to successfully quit smoking. I recommended follow-up for this patient with a phone call in 3 to 7 days for counseling to assess smoking cessation progress and provide support. The rationale behind this is that a brief 3-minute counseling to urge the patient to quit smoking improves cessation rates by 5 to 10% based on GOLD guidelines. For non-pharmacologic therapy, I recommended to refer the patient to smoking cessation support groups or counseling programs, and to begin a healthy lifestyle habits when they have the urge to smoke, such as walking, stretching, mindful thinking, meditation, brush their teeth, etc. For patient education, the patient needs to allow the lozenge to dissolve over 10 minutes. Do not chew or swallow the lozenge. They may feel a warm or tingling sensation while the lozenge is dissolving, and they should occasionally rotate the lozenge to different areas of their mouth while it is dissolving. No food or beverages 15 minutes before or during use with the lozenge, especially with acidic drinks such as coffee, juice, or soft drinks. And the treatment duration is 12 weeks. Also advise the patient that their first attempt to quit smoking may not be successful, but they should continue their progress for quitting. For a patient-specific optimization of their inhaler regimen, I recommended to discontinue fluticasone 100 microgram MDI because it's suboptimal therapy, and to start a combination long-acting beta-2 agonist inhaled corticosteroid meter-dose inhaler, fluticasone 100 microgram in combination with salmeterol 50 microgram, also known as Advair Discus. 1 puff orally in the morning and evening every day, about 12 hours apart. And this is FDA approved for COPD. The rationale behind Advair is that salmeterol twice daily significantly improves FEV1, lung volumes, dyspnea, health status, exacerbation rate, and number of hospitalizations based on GOLD guidelines, evidence level B. Also, regular treatment with inhaled corticosteroids improves symptoms, lung function, and quality of life, and decreases frequency of exacerbations in COPD with FEV1 less than 60%. Remember, our patient was at a FEV1 of 52%. And this is GOLD guidelines evidence level A. Also recommend for the patient to continue their short-acting beta agonist albuterol. And we'll monitor for safety for heart rate, blood pressure, or have the patient report if self-monitored, for worsening symptoms despite treatment. And for efficacy, resolution of their wheezing, increased exercise tolerance and weight loss, and also quality of life. I recommended a 30-day follow-up appointment for this patient to recheck their inhaler technique, evaluate their symptoms, and reassess their quality of life, to determine their adherence with their meter-dose inhaler, and they can repeat spirometry in 1 year. For non-pharmacologic therapy, I recommended a referral for pulmonary rehabilitation, and the rationale here is that pulmonary rehabilitation improves shortness of breath, health status, and exercise tolerance in stable patients, evidence level A, GOLD guidelines. Also to begin an exercise regimen or regular activity, and also cardiology follow-up to assess prolonged QTc interval, which presented today. For patient education, I advise the patient of the importance of using their long-acting beta agonist regularly, and that the short-acting beta agonist is for limited use as needed for their shortness of breath. That excessive use of the rescue inhaler can lead to more side effects, and to provide training for inhaler technique for best drug delivery. For assessment of disease of depression, based on the patient's HAM-D score of 16 and reported symptoms, the patient has moderate depression. The patient is not currently on any therapy for their depression. They have no symptoms of suicidal ideation, bipolar disease, mania, anxiety, or insomnia. And the goals of therapy are to alleviate signs and symptoms of depression and improve their quality of life. The plan for depression is to discontinue the planned therapy to restart citalopram, which is inappropriate due to the reports of erectile dysfunction and diarrhea. And also citalopram has a dose-dependent increased risk of QT prolongation. I recommended start bupropion, hydrochloride, immediate release, 100 milligram PO Q-Day for 7 days, BID for 7 days, and then TID for 14 days. If the patient is able to tolerate the 300 milligram daily dose, then the prescription may be switched to bupropion SR 150 milligrams BID. And the rationale for bupropion is that pharmacotherapy, again, when combined with nicotine replacement, reliably increases long-term smoking abstinence rates based on GOLD guideline. Bupropion is FDA approved for the treatment of major depressive disorder, and lower dose and frequency are recommended with hepatic impairment. And an article on assessment and treatment of depression following myocardial infarction shows that bupropion has negligible to minimal effects for causing hypotension, cardiac conduction or heart rate abnormalities, or pro-arrhythmic effects. For monitoring bupropion for safety, we will look at increased heart rate, constipation, nausea, confusion, dizziness, tremor, agitation, anxiety, or dry mouth. The bupropion does have a drug-drug interaction which may cause an increased exposure to their metoprolol. And systemic steroids and bupropion may lower the seizure threshold. However, the Advair is considered an inhaled corticosteroid. And for efficacy for bupropion, we will look at improvement in clinical signs and symptoms of depression, improvement in the HAM-D score, and also additional improvement benefit with the smoking cessation. I recommended a follow-up in 30 days for this patient to assess their improvement and repeat the HAM-D questionnaire, to repeat general chemistry labs, and assess renal and liver function to help guide bupropion dosage adjustments. For non-pharmacologic therapy, I referred the patient to psychiatry to discuss CBT and to consider individual or group therapy or support groups. And for patient education, we want the patient to avoid activities that require mental alertness until the drug effects are known. So, for example, to avoid driving when they first start the product, to take at the same time each day, preferably in the morning, to avoid insomnia, to avoid use with alcohol, and if they miss a dose, they can resume with the next scheduled dose, and to discuss expectations of the time response to bupropion. For example, they can expect to see improvement in anxiety, sleep, and appetite during week 1, improvement in energy, concentration, and memory during weeks 2 and 3, and improvement in mood, hopelessness, or suicidal thoughts during weeks 4 to 8. And also, we want the patient to report any changes in heart rate or blood pressure, worsening of depression, or occurrence of suicidal ideation. Thank you.